Yeah, thanks, Pradeep. Hi. Hello, everyone. You can use.
Yeah, please start.
Good afternoon, respected faculty and my dear colleagues. I am going to present an interesting case of acute corneal eye drops. So, from the history, a 27-year-old male presented to a tertiary center with complaints of photophobia, redness, and discomfort in the left eye for the past 1 week. And from the systemic history, we knew that he's a known case of Down syndrome. And according to hypothesis, hydrops has been associated with an increased frequency in Down syndrome, and it is suspected that either the genetic modification has led to the biochemical changes, and these patients also have a high frequency of oculodigital phenomena. So that is hypothesized to be the cause of increased frequency of hydrops in these patients. So on examination, in the right eye, the patient had a uncorrected visual acuity of 6/60, which is improving to 624 in pinhole. This was the first presentation of the patient, so he had not received any spectral correction yet. In the affected eye, the visual acuity was counting fingers, and the projection of rays was accurate in all the quadrants. The intraocular pressure was normal, and in the cornea, in the right eye, as we can see in the image, it was appeared normal, and while in the left eye, as we can see in the center, there is diffuse edema, and the rest, the peripheral cornea is clear, but in the center we can see the eye drops. So we subjected the patient to investigations. Tomography on shine flux imaging was done, and in the affected eye, as you can see in the black areas, the entire points could not be captured. So AIOS2025 was done for the patient, and in the affected eye we can see there were large interstromal clefts which were visible, and the thickness was increased, as we can see, whereas there was a break in the descemet membrane which was visualized on the AIOS2025. So we labeled the patient as both eye keratoconus. Right eye was stage 1 in amsoclemic grading, left was the advanced stage, and initially the conservative management was begun, but the patient was planned for surgery. So the patient was planned for the intra-operative OCT guided stromal compression sutures, as well as intracameral SF6 gas. And it has also been described that using the OCD guidance by Professor Sharma et al., that the clefts can be drained, but since there was a large break, drainage of the clefts with incision was not planned in this patient. At the end of the surgery, we can see that visibly the edema appears reduced, and on post-op day 1, the cornea is much clearer, and bandage contact lens was placed. This is the post-op day 1 AIOS2025. So in discussion, I'd like to discuss the paper by Dua et al., which has described that it's not just the break in descemet membrane, but the pre-descemet membrane as well, which gives rise to eye drops. And there are various types of breaks which are described. And I think in summary, a recent review article by Bafna et al., which describes the protocol in which conservative management, if which fails, like in our case, the surgical intervention usually involves sealing the break, or in a later stage, desec, demec, or in the further stage for the opacity, a DALC later. Thank you.
So, how did you check the intraocular pressure in these cases?
So in this case it was difficult, but we took the picture on the week 7, day 7 of the presentation. At the presentation there was an area of clear cornea, so we tried to apply.
Because it is not that
Yes,
easy to do. Either you have to use tonopan,
right, sir.
and that is what, and that too, when you open the eyes in a pediatric age group, that creates pressure on the eyeball.
Right, sir.
And secondly, for the other eye,
Sir, otherwise we planned cross-linking for the patient, because at the presentation itself the patient had developed eye drops in one eye. So the other eye was planned for corneal cross-linking.
so what was the stage in the other eye?
So in the other eye, it was early stage, sir. Since the pachymetry was above 400, and the keratometry was also below 47 diopters, the steep keratometry. So he was advanced in one eye, but the other eye was in the stage 1.
What will
In
you?
interest of time, say if you allow, the next speaker can come up, Dr. Anusuya Kar.
Thank you.
Thank you, sir.
I'll request all speakers to stick to the time.
Good afternoon, everyone. Today I'm going to present a case on role of conservative therapy in ocular trauma case. So ocular trauma accounts for about 5% of all blindness cases globally, and it is classified according to the Birmingham Eye Trauma Terminology System, where if there is any breach in the eye wall that consists of the sclera and the cornea, it is known as open globe injury. If no, it is known as closed globe injury. In closed globe injury, again, there can be uh, contusion where there is no direct trauma, but due to indirect forces the injury occurs, and if there is any partial thickness injury, that consists of lamellar laceration. In open globe injury, if there is an injury with blunt trauma, then it is known as rupture. In laceration, there is injury with pointed object. If Again, it can be divided into penetrating, perforating, and intraocular foreign body. So my case is a 23-year-old male who presented to the emergency with injury with the blunt end of the nail. He was a carpenter by profession, and it had hit him in the eye in a projectile fashion. So patient was complaining of diminution of vision in that eye with redness, pain, and foreign body sensation since the time of injury. On ocular examination in right eye, everything starting from visual acuity to fundus was within normal limit. In left eye, he had a visual acuity of hand movement positive and a small conjunctival tear adjacent to the limbus with surrounding congestion, and grade 3 hyphema with traumatic mydriasis. We could not get any view of the fundus because of the hyphema, and IOP was borderline low, that is 10 mmHg as compared to 18 mmHg in right eye, and the cause for low IOP was thought to be due to ciliary, which was presumed to be due to ciliary shutdown. So according to the ocular trauma score, our case comes to have an ocular trauma score of 3. Patient was, a CT scan and USG B scan was done, which was within normal limits. So a diagnosis of left eye conjunctival tear with grade 3 hyphema and traumatic mydriasis was made. And patient was started on oral steroids, antacid, antibiotic, vitamin C, and topical steroid antibiotic, cycloplegic, I was advised propped up position. At follow-up at 1 week, the visual acuity improved to 636, improving to 618 parts, and IOP also improved to 13 mmHg with resolving hyphema. On clearing of the hyphema, we could see a choroidal rupture in the left eye. So what was unique in my case was hidden ophthalmological finding with spontaneous resolution of hyphema and restoration of a reasonable visual acuity within 1 week only. Whereas according to the ocular trauma score, the 6-month probability of getting a 636 vision was only 28%. We saw similar improvement in visual acuity in 1 week. So that clinically implies that conservative management also plays an important role in ocular trauma cases, and there should be proper selection of those candidates based on the severity, presentation, and ancillary tests. These are my references, and coming to my take-home message, ocular trauma management case varies from case to case, and it requires careful decision-making between conservative and interventional approaches. Thank you.
Only one question, that if you are faced with a vitreous hemorrhage case and you are not able to visualize the macula, how do you come to know that there is a subretinal bleed or not? If there is a submacular hemorrhage, will you like to intervene early or not?
Should be, sir.
So the ideal timing which has been given is 10 days. So if you are having a vitreous hemorrhage which is precluding you to see the macula in 10 days, it is a wise option to intervene.
Okay, sir.
We can have the next speaker
Thank
ready,
you, sir.
Dr. Pankhudi Verma. I request the next speaker in key to be present on the dais right after the finishing of this presentation, Dr. Tejal Srivastav. She can be ready.
She can be ready on the other side.
Dr. Tejal is here. Dr. Arhan Das Gupta.
Go on, Father. Come here. Come in front. You can start.
Good afternoon. I am going to present a mysterious case of traumatic anterior chamber fistula, a BLEBST. Ocular trauma is a significant cause of visual morbidity in pediatric patient, often leading to long-term complication if not promptly diagnosed and managed. Retained IOFP are a potential consequences of ocular trauma. A 4-year-old boy presented with complaint of swelling in white part of the right eye for 2 months, which progressively increased to the present state. History of trauma with pen was present there while playing with brother 8 months ago, for which previous consultation was done for redness. In the right eye, the best corrected visual acuity was 6/24 and the pressure was 6 millimeter of mercury. And the conjunctival pleb was present at 5 o'clock, which was 1 millimeter away from the limbus, about 1 into 1 mm, with a central pigmentation suggestive of a foreign body. The anterior chamber, we can see that the AC is formed deep. On fundus examination, we can see disc edema. So the slides are moving actually, it's not proper. Yeah, it's moving on its own. Yeah.
Maybe you are doing it?
They may be timed, so you can go back, press the move back.
I think from there only they can change.
Kindly move back the slides. Kindly move back the slides.
Use timings, can you change it? So AC was formed in deep, and on fundus examination we could see disc margin was blurred, along with it chorioretinal folds was present. On investigation, and no, it's again moving.
Please go ahead.
Use timings, I think box is clicked there. It's the slide, so.
You can you go further to the next slide? Check it.
So I can't do it from here. It's not moving from here. Slideshow option, use timings, the checkbox is clicked there. Use timings.
Can we ask the next speaker to present in the time?
Yeah, we can, or if she can finish it.
Yeah, sir, I think it's done. I can do it now.
Dr. Pankti, you can present again. Dr. Arhan, in the meantime, you can start. We'll grade you again with your time. Please. You can go
can check
to
with the
AV
audio
people and
also.
check what you want.
Okay, good afternoon. I'm here to present a rare case of medusa head in the eye, unraveling the enigma. Now, a medusa head in the eye, what can be the line of thought? Maybe a phacomatosis or an angioma, or maybe some peripheral vascular tumor arising in the retina, or maybe some systemic features of hypertension or AV malformations. Well, in our case, it was a case of von Hippel-Lindau syndrome, which presents to us with hemangioblastomas, increased risk of renal cell cancer, pheochromocytoma, pancreatic lesions, eye lesions, endolymphatic sac tumors, liver and renal cysts. It generally manifests within the 3rd to 4th decade of life, while the mean age of onset of retinal hemangioblastoma, which is one of the first manifestations, is around 26 years. My patient was a 23-year-old male belonging to a rural background who presented to us with gradual onset dimness of vision in the right eye for last 2 to 3 years with occasional floaters, which were not associated with any pain, and there were no aggravating or relieving factors or history of previous trauma or fever. The left eye was blind since birth, and there was no medical consultation done for the same previously, with a discoloration of the overlying skin. Family and personal history yielded nothing significant. Vital parameters for the patient were normal. Now, coming to the ocular examination of this patient, the visual acuity in the right eye was 6/60 with round regular reactive pupils and extraocular movements full and free in all directions. The left eye was a blind eye with an eye positioned downwards and outwards in primary gaze. On anterior segment evaluation, the right eye had a normal anterior segment with a golden yellow fundal glow, while the left eye showed conjunctivalized cornea with posterior synechia and complicated cataract. The dilated fundoscopy for this patient showed dilated tortuous vessels around the disc with diffuse macular exudation extending up to the periphery, and the superotemporal arcade branch acted as a feeder to peripheral lesions that were 2 in number, about 2 into 3 millimeters in size. So this is our fundus picture that emulates the medusa head, and these are the peripheral lesions that were visible on dilated fundoscopy. So the investigations done, they showed 3-OCT macula showed diffuse macular exudates with cystoid macular edema, and fluorescent angiography showed hyperfluorescence with a filling of lesions during capillary phase and early leakage. Here it has been shown. And these are the differential diagnoses that were considered. The patient went up for an injection anti-VEGF dose along with guided cryotherapy around the peripheral tumors. The blood investigations yielded nothing significant, and the systemic investigations showed bilateral renal cortical cysts, even though the other systemic investigations were normal. On further discussion, a family history of probable early death due to CVA in a parent was known. The final diagnosis was right eye retinal capillary hemangioblastomas in a case of VHL syndrome associated with renal involvement. And after 2 weeks after follow-up, we saw that the vascularity in the tumors had reduced even though macular edema was resistant to treatment. Because it is the only seeing eye, the patient has been kept under close follow-up and will be taken up for EBRT or plaque brachytherapy if the need arises. He may also undergo a trial of belzutifan. Now, these cases require a plethora of investigations because the appearances of such cases are deceptive, and systemic evaluation along with pedigree analysis and screening of family members is a must in such cases. This is my take-home message and my acknowledgements and references.
Dr. Arhan, why did you discourage VR surgery in this particular case? It will be a lovely case to operate with a good result. Why you did not offer VR surgery to this case?
Sir, the patient is slightly apprehensive because this is the only one seeing eye.
That is even more so the reason that if you are going to wait, these lesions are not going to go, and they respond wonderfully to VR surgery. So probably that is one thing which I will like to try before subjecting the patient to EBRT. You are going ahead with an EBRT procedure in a one-eyed patient will not be
we
justified.
have consulted the oncologists. They said to keep under close follow-up. If the need arises, we will go for it. Other than that,
Dr. Pankri, you are ready with your presentation? Sir, if you allow, we can start our presentation.
Good afternoon. I am going to present the mysterious case of traumatic anterior chamber fistula, a Bleb's tail. Ocular trauma is a significant cause of visual morbidity in pediatric patients, often leading to long-term complications if not promptly diagnosed and managed. Retained IOFP are a potential consequence of ocular injuries and may remain undetected, especially in cases with subtle or atypical presentations. My case is a 4-year-old boy presented with swelling in white part of the right eye for 2 months, which progressively increased to the present state. There is a history of trauma with pen while playing with brother 8 months ago, for which previous consultation was done only for redness. On presentation, the best corrected visual acuity was 6/24 in right eye with a pressure of 6 mm of mercury, whereas in left eye it was 6/6. On conjunctiva, we could appreciate a bleb which is present at 5 o'clock, 1 mm away from the limbus, about 1 into 1 mm size, with a central pigmentation, query foreign body. The AC was formed deep, and we could see the bleb. The rest anterior segment finding was within normal limit. And right eye on fundus examination, we could appreciate that the disc margin of blood with chorioretinal folds were seen in the fundus. In the left eye, the fundus was within normal limit. So based on our clinical history, we came to a provisional diagnosis of a foreign body in situ forming a bleb causing hypertensive maculopathy. On investigation, we found that NCCT head with orbit, there was no abnormalities seen, that is no foreign body was present. On multicolor imaging, we could appreciate the chorioretinal fold, and on OCT disc, we could see the disc edema is present in the right eye. On anterior segment AIOS2025, we could appreciate the bleb is formed beneath the limbus, and we could see the scleral integrity is also not there. So we took the patient for wound exploration with scleral tear repair. We found that there was no foreign body in situ as such, but there was iris incarcerated, which was acting as a ceton, which was acting like a ceton, forming a conjunctival bleb, which was further causing the hypertensive maculopathy. So we did a wound exploration, and gonioscopy was also performed to see if anything is present in the angles, and then scleral tear repair was done. This is the intra-op video where we can see that on injecting the dye, when we inject the trypan blue, we can see it is coming from the other side where the perforation was present, suggesting that the fistula was present between the anterior chamber and the sclera. The scleral tear repair was done. So on follow-up, post-op 1 month, the vision improved to 6/6, pressure was 16 mm of mercury, and on fundus examination, we couldn't find any disc margin edema or chorioretinal folds. So what was unique in my case? Traumatic anterior chamber fistula masquerading as a bleb in this case was an unusual sequelae of a penetrating ocular trauma. Appearance of bleb-like lesion is absence of previous surgery led to initial diagnostic confusion. Cases like this may be overlooked as post-traumatic scarring or self-sealed perforation, delaying critical intervention. The metallic foreign body can remain relatively inert for a long period without causing devastating infection, so we should rule out. And managing AC fistula requires a balance between preventing leak and maintaining ocular integrity, especially in the pediatric cases. So coming to the take-home message, we should advise all the B-scan, anterior segment OCT and CT MRI. Early recognition and intervention are essential to prevent long-term visual impairment. Thank you.
Dr. Gaurav Lalla can come over. Did you do a serial test in this case?
Yes, sir. Serial was negative in this case. Yeah. Intraoperatively also it was negative.
Do you really need to inject the dye in the... Apologies. Do you really need to inject the dye in the anterior chamber? If you stain it with Cedal, you'll see the leak.
But if we remove the peritomy, then it was seen. Like conjunctiva was present over it. So after peritomy, the leak was present, obviously.
Yeah.
Thank you, sir.
Good afternoon. Today's case is titled Ophthalmic Manifestations in Children with Type 1 Glycosylation Disorder, a case report. So, congenital disorders of glycosylation are a group of inherited metabolic diseases caused by defects in glycosylation pathway, leading to multi-system involvement. Clinical manifestations include developmental delay, intellectual disability, hypotonia, hypoglycemia, hypothyroidism, adrenal insufficiency, protein-losing enteropathy, chronic diarrhea, and failure to thrive. Esotropia linked to underlying neuromuscular dysfunction affecting eye movement, optic atrophy which can lead to visual impairment, retinal dystrophy, ptosis, refractive errors. Our case is a 9-year-old male known case of type 1 glycosylation disorder, came to our setup with for ophthalmological evaluation. Past history: at 5 months of age, the parents noticed child was not feeding properly with frequent regurgitation. He was unable to gain weight appropriate for his age, inward deviation of right eye at 1 year of age. Gross motor and language milestones were delayed, hypotonia was present, MRI brain was done as suggested by the pediatrician, which suggested a prominent cisterna magna, hypoplastic inferior vermis suggestive of Dandy-Walker variant. Transferrin isoelectric focusing elevated acylotransferrin and diacylotransferrin, and low tetracylotransferrin was present. On ocular examination, visual acuity was 636 and 618. Cornea, conjunctiva, pupil was WNL, anterior chambers was within normal limit, fundus was also within normal limits. We did retinoscopy under homide, which revealed a refractive error of 0.75 and 0.5 spherical, with -1 cylinder in each of the eyes, best correcting to 618 and 612. In orthoptic evaluation, there was primary ocular deviation, right esotropia 20 degrees. The angle of strabismus showed deviation of 40% diopters of esotropia in primary gaze. No ptosis was seen. There was abduction deficit in each of the eyes. In this case, the patient presented with alternate convergent squint, deficient abduction, and significant refractive error. The presence of abduction deficits without evidence of cranial nerve palsy suggests a broader neuromuscular impairment associated with PMM2 CDG disorders. The absence of optic atrophy at this stage does not preclude its potential development in the future, highlighting a need for long-term ophthalmic evaluation and surveillance. The normal anterior segment examination in this patient further suggests that the primary deficit lie in the neuromuscular function rather than structural abnormalities. Ophthalmic signs like esotropia, abduction deficits, refractive error may be early indicators of CDG. These manifestations reflect underlying neuromuscular dysfunction rather than primary structural issues. Early ophthalmic evaluation is essential for timely diagnosis and management. Regular eye checkups can prevent amblyopia and long-term visual impairment. Infantile esotropia with abduction deficit with amblyopia with hypotonia is not an uncommon finding in rare congenital glycosylation disorder, and children diagnosed with these conditions should undergo thorough ophthalmic evaluation as early as possible.
Dr. Uttam Dhaka can take the stage.
So why do you call it the category of CDG?
So there was the gene mapping was already done by the gynecologist and the pediatrician, and we had the report on presentation.
Why do you correlate the alternating esotropia or esotropia with this CDG?
It has been found in the earlier studies as well that the
But
children.
there were other things also apart from this optic nerve, optic atrophy
Yes.
and ptosis and
Yes, sir.
other findings.
Yes.
Only esotropia is there. On the basis of that, how would you call it that it comes in the category of CDG?
it was like we had the report and then we found these symptoms and signs present.
Okay.
Thank you, sir.
Good afternoon, everyone. My topic is alternating blepharotosis with lateral rectus synkinesis. It belongs to the group called congenital cranial dysgeneration disorder, CCDS, which are non-progressive disease from aberrant cranial nerve development. They result from miswiring leading to abnormal innervation of extraocular muscles. My case was a 10-year-old female child presented to the OPD of GNEC with the right eye ptosis and exotropia of 10 degrees. And she had a positive family history of severe ptosis in the mother in the right eye only. On examination, the patient had right eye severe ptosis with margin reflect distance 1 of -2 mm and exotropia of 10 degrees. There was a negative history of no facial asymmetry or abnormal head posture. The Bell's was fair in the right eye, while in the left eye it was good. There was no evidence of Marcus gun phenomenon, and it was associated with torsional nystagmus and a poor visual acuity in the right eye and a good visual acuity in the left eye. On dextro version, the right eye showed marked improvement in the ptosis while the left eyelid developed drooping. Conversely, on levo version, the ptosis in the right eye increased while the left eye remained elevated. There was a mild limitation of elevation in both eyes. There was no evidence of any globe retraction on attempted adduction or abduction. MRI was grossly within normal limits. So the parents were motivated for the alignment in the primary case. So we did 8 mm LR recession along with the tarsofrontalis sling in this patient. So this is the left side is the pre-op images in which we can see right eye severe ptosis. On dextro there's ptosis in the left eye. On levo there's correction in the ptosis in the left eye. This is the post-op image which is on primary case. It is the eyes are aligned and the ptosis is corrected in the post-op images. Video is not showing.
Display. Video will play. Okay.
It's not playing. Okay. So what is unique in my case? This case presented a novel synkinetic pattern where ptosis varies with horizontal eye movements due to possible lateral rectus and levator palpebrae superioris synkinesis, which violates the classical ocular motility laws. Unlike previously reported cases, it exhibited exotropia, nystagmus, and no globe retraction, making it a distinct phenotype with the congenital cranial dysgeneration disorder spectrum. Clinical implication is that it can be shown that even with complex degeneration patterns, targeted surgical intervention combined LR recession with tarsofrontalis sling can yield a satisfactory ocular alignment and ptosis correction in primary case, prioritizing functional vision over perfect motility in all cases. So, thank you.
Good morning, everyone. I am presenting a clinical case of posterior polar cataract. It is an elevated plaque-like onion ring shaped or bullseye appearance opacity, which is present on the posterior pole of the lens and densely adherent to the posterior capsule. It is hypothesized that PPC results from hyaloid artery persistence, and it is an uncommon form of congenital cataract with an incidence of 3 to 5 in 1,000. A 40-year-old female presented to our OPD with the chief complaints of diminution of vision for near and distance, which is more in left eye than right eye, for 5 months. And it is gradual in onset, painless, and progressive in nature. She has been instilling eye drop betamethasone as over-the-counter drug for 10 years. And the patient's sibling and both parents had also undergone cataract surgery in both eyes at the age of 40 years and 50 years respectively. And there is also a history of eye drop betamethasone instillation in her family. On ocular examination, uncorrected visual acuity in the right eye is 6 by 18 and in the left eye is 6 by 60. And the best corrected visual acuity is in right eye plane 6 by 18 and in left eye 6 by 24 with the correction of -3 diopter spherical and -1.25 diopter cylindrical. And IOP, pupillary reaction and axial length are within normal limit. On slit lamp examination, anterior segment is within normal limit, and here we can see the nuclear sclerosis grade 2, cortical cataract, and a discoid plaque-like opacity on the posterior part of the lens, which is more in the left eye than right eye. On investigation, here we can see the opacity, which is densely adhered to the posterior capsule, which is more in the left eye than right eye. And here the management. Left eye phacoemulsification with PCIOL done under topical anesthesia, and here trepan blue dye is injected, and capsular access was done. Hydrodissection was not done to avoid the stress on the compromised posterior capsule, and here hydrodelineation is done, and all parameters was kept low. Here we can see the pseudo hole sign, which implies the impression of the onion ring shaped opacity on the posterior capsule of the lens. And surgery went uneventful. And what is the unique in my case? As there is history of prolonged betamethasone eye drop use likely contributed to the development of cataract, and clinical implication emphasizes cautious use of corticosteroids to prevent the drug-induced cataract. Steroid-induced PSC cataract would mimic a true or pseudo-PPC cataract in morphology, and such a diagnostic dilemma can lead to errors in the surgical planning and management of the difficult cases. And it is challenging to remove surgically due to their location and potential for complications like PCR with vitreous loss. And take-home message: we should monitor long-term use of corticosteroids to prevent the complications, and experienced surgeons should take up PPC cataract surgery with backup for vitreoretinal surgery. Thank you.
Dr. Monica Arora, please.
Can I ask one question? Babita, apart from the precaution of not doing hydrodissection, what else you will take care of? And you have taken care while doing the surgery?
Hydrodissection should not be done. Nuclear rotation also should not be done, and the parameters should be on the lower side.
And one more important thing.
And
We should fill the chamber with viscoelastic
Yes,
while
sir.
removing the hand pieces. Irrigation should remain on, and viscoelastic should be filled in the anterior chamber. Okay, next.
thank you.
Good afternoon. My case is bilateral malignant glaucoma, a nightmare in the dark. A 22-year-old female presented with the blurring of vision in left eye for 2 months, which was sudden in onset, severe pain associated with redness and with intense headache. The patient record showed baseline high IOP in the right eye 28, and in the left eye it was 36 millimeter of mercury. Therefore, the patient was planned for laser peripheral iridotomy, and patient was kept on topical AGM. But after PI also, in the left eye the pressures were raised, and therefore on the maximum medical therapy. Therefore, the patient was planned for left eye fornix beak strap surgery. After the surgery also, in the left eye the pressure remained high. The clinical image shows in the left eye it was a thin cystic bleb with the AC shallow peripheral as well as central with the IOP of 22 millimeter mercury. On gonioscopy, the angles were closed in the right eye, whereas in the left eye the ostium was patent with the angles closed. On UBM, it was a plateau iris configuration, and on A scan the axial length showed 21.70 in the right eye, whereas in the left eye it was 21.75. On HFA, the left eye was having a superior arcuate, whereas in the right eye it was a nasal step. The A scan was. My provisional diagnosis was both eye PACG in young with left eye operated fornix based trap. So what was the management? We took the patient for left eye AC reformation with sodium hyaluronate. Postoperatively we can also see the AC was shallow centrally as well as peripherally. So we took the patient for clear lens extraction along with anterior vitrectomy with hyalodectomy and with posterior capsulectomy. Why it is not playing? So it was a routine cataract. So after we were not able to put the dye, and we did the anterior vitrectomy, and after that, doing the anterior vitrectomy, we were able to form the AC. And we were able to do capsulorhexis easily. And it was a routine clear lens extraction. After putting the IOL, again we did the posterior capsulotomy. And we were able to form the AC. So post-operatively, the vision was 6/6 in the left eye. We did the same management in the right eye also. The IOP was controlled, AC was well formed, and we kept the patient on the atropine eye ointment, 1% HS. So a summary of a case was both eye primary angle closure glaucoma in young with plateau iris with operated trab, post-trabeclectomy recurrent shallow anterior chamber with high IOP despite filtering bleb suggestive of malignant glaucoma. So we did both eye clear lens extraction with anterior vitrectomy with highlightectomy with posterior capsulotomy.
Dr. Sheel Mishram, please. How long you have followed up this patient?
So we have I have seen 6 months back also, sir, this patient.
So these patients, when you follow them up with long term, even with pseudophacosis, they can have malignant
Yes, sir.
glaucoma,
Yes,
and
sir.
they will require a complete vitrectomy
Yes,
to
sir.
get rid of the condition.
Yes, sir.
So the message should be a complete vitrectomy when you have a malignant glaucoma. Dr. Sheel, please.
Good afternoon, everyone. I'll be presenting the rings and hooks managing subluxated traumatic cataract. There's no conflict of interest and no financial disclosure. Subluxation is partial displacement of lens from the patellar fossa. It could be congenital or acquired as in case of trauma. Management depends upon the amount of subluxation. Up to 3 clock hours, a PMMA IOL could be used along with a CTR can be used. In 3 to 6 clock hours, we can use a CTR or a modified CTR with a single loop with IOL implantation. In 6 to 9 clock hours, a modified CTR with a double loop or a combination of CTR or with CTS could be used. In more than 9 clock hours, cataract extraction with SFIOL or ACIOL could be done in same or different setting. This case is of a 9-year-old male child resident of Bhojpur, Bihar, who came with complaint of diminution of vision and whitish reflex from the left eye since 1 year. There was history of trauma to left eye with firecracker a year back. No deviation of eye or floaters or flashes of light was seen. The vision in left eye was hand movements close to face and PL positive and PR accurate in all quadrants. The IOP was normal, facial symmetry was there, extraocular movements were full and free. Orbit, the margins were regular, lids adnexa, conjunctiva was normal, cornea was clear, but the anterior chamber depth was variable. Iris showed a sphincter tear at 8 o'clock position with wide gape, and the pupil was irregular with mid-dilated with sluggishly reactive. Lens was cataractous with 7 clock hours of temporal subluxation from 6 o'clock to 1 o'clock position. The fundus findings were within normal limit. The right eye findings were within normal limit. Diagnosis of a left eye traumatic cataract with 7 clock hours of temporal lens subluxation from 6 o'clock to 1 o'clock position with iris sphincter tear at 8 o'clock position was made. The patient was planned for left eye phacoaspiration with PCL implantation with capsular tension ring and capsular tension segment. There's a short video. AC entry was done, capsule was stained, capsulorhexis was done. OVD was injected and the capsular margin was stabilized using capsular hooks, and a capsular tension ring was inserted in the capsular bag to stabilize it, followed by phacoemulsification. After which a scleral pocket was made for insertion of anterior capsular tension segment, which was threaded with a 10-0 straight needle proline, and it was inserted in the capsular bag, and the proline suture was exteriorized using a 26 gauge needle, and it was secured by tying the proline suture in the scleral pocket, and the conjunctiva was closed. Post-operatively, the vision was hand movement close to face, the PCIL was in the bag, it was well centered, CTR and eyelids of the CTS could be visualized. Follow-up after 3 weeks. The visual acuity was 6/60. There was centered and stable capsular bag. CTR and CTS was in situ, and PCL was in the bag, but a primary PC plaque was present in the center. Clinical implications, CTR have been successfully used in traumatic cataract with less than 6 clock hours of zonal lysis. Fixated capsular tension devices such as CONU-modified CTR with eyelets or a capsular tension segment with eyelets may be required to ensure centration and stability of the capsular bag in eyes with greater extent of zonal lysis. My take-home message is, in cases of severe zonular weakness, a CTS on its own does not expand the bag, as well as CTR alone cannot be used to center the bag. This can be overcome by using a combination of the capsular tension segment with the capsular tension ring. Thank you.
So, what did you do for the posterior segment evaluation?
So for the posterior segment, the indirect ophthalmoscopy was done, it was visible.
And because macula could be affected due to trauma.
Sir, it was visible from the from the zonal lysis area, we could visualize the macula and the fundus.
Post-operatively, you should have done evaluated by OCT macula. That would have been better to tell us about the poor visual outcome.
So probably it was due to the primary PC plaque which was
that is there, but
Dr. Deepti is here.
Manjot Kaur, Deepti.
Dr. Sheel, one question for you before she starts. So you ended up with a visual acuity of 6 by 60, as sir was saying, after putting in a CTR. Wouldn't it be better to do a SFIO?
Sir, can be done. It can be done.
Tejal Srivastav, is he here? Tejal is absent.
Can we have Dr. Deepti's presentation?
40.
Lupus incognito. Lupus incognito, LUPUS. Dr. Deepti, I hope you loaded your presentation.
Just check it. अभी आपका क्या निकल जाएगा कल फिर आपके लिए तो आसान है
Good afternoon, one and all. I'm Dr. Deepti, and I'll be presenting a case called lupus incognito, a rare ocular presentation of systemic lupus erythematosus. I have no financial interest to disclose. SLE is an autoimmune disease characterized by chronic overactivation of the immune system leading to inflammation. So SLE has a wide variety of clinical presentation, which includes fatigue, arthralgia, myalgia, photosensitivity, fever. Ocular involvement occurs in about 33 to 50% of patients in SLE. The most common ophthalmologic manifestation of SLE is keratoconjunctivitis sicca, and the most vision-threatening ocular manifestation is lupus retinopathy. So moving on to the case details, a 13-year-old female presented with complaints of bilateral redness and photophobia since 1 month, and she was treated elsewhere with cycloplegics and antibiotics, and she was also given a trial of antifungals, but with no improvement. So she came to us with persistent redness and photophobia. She was a known case of SLE since 8 years of age, and she was initially on treatment with HCQS, mycophenolate mofetil, and azathioprine. She stopped taking the treatment 3 years ago, and when she presented to us, her visual acuity was, uncorrected vision was 6/6 parts in right eye with no pinhole vision improvement, and 6/12 parts in left eye with vision improving to 6/9. On slit lamp examination, some of the significant findings were the right eye, both eyes showed circumcorneal congestion, with the right eye having a central corneal endothelial plaque measuring around 4 by 5 millimeters. And there was a mild AC reaction with cells of grading 2+ and flare of 1+. And the left eye as well showed diffuse keratic precipitates with AC reaction of cells 1+ and flare 1+, but the cornea was clear. A clinical timeline of how she presented to us, and on day 2 we performed a diagnostic anterior chamber tap, and on day 3 her cornea was clear because the plaque was removed, and the AC was also quiet, and she was on empirical treatment with topical steroids and antibiotic cover. And on day 10, the UVA consultant decided to start her on immunosuppressives and oral steroids after consulting her rheumatologist. And on day 13, when we followed the PCR report, the anterior chamber tap sample was sent for an array of microbiological investigations, which I'll be telling in the slides to come. And the PCR report turned out to be negative. And on day 21, the oral steroids were stopped by the patient herself, and the plaque was noticed to recur after that. And on day 35, when she was again restarted on immunosuppressives and steroids, the plaque resolved, and on follow-up, the plaque completely resolved with a clear cornea and the vision improving to 6/6. So some of the clinical photographs, this is the right eye showing the central corneal endothelial plaque, and the left eye was clear, and the AIOS2025 showing an endothelial plaque with the plaque boundary being very clear. And a B scan was done because the fundus view was hazy, and the B scan was within normal limits. Why my case is unique is corneal endothelitis is a very rare ocular manifestation of SLE, and only one case report has been reported so far in a 45-year-old female with a bilateral transient keratoendothelitis, and it's been reported by J.H. Varga et al. And this is the only pediatric age group of such manifestation that has been reported. The clinical implications would be that corneal endothelial plaques on AIOS2025 the etiology can be decided based on the boundary between the endothelium and the endothelial plaque boundary. So if it is wavy, it is more characteristic of fungus, whereas if it is clear, it is said to be, it is more towards bacterial.
Dr.
But in our
we
case,
can wrap up.
yes, sir. So my take-home message would be SLE could also manifest as a corneal endothelial plaque, although it's very rare. And it's very important to take a good, thorough systemic history and do a detailed systemic evaluation. Anterior chamber tap and PCR play a crucial role in diagnosing the etiology, and regular follow-ups are crucial too. Thank you.
With this, we close this session. I request all the panelists and the speakers to come for a photograph, and I invite our retina session panelists to come and take over the stage.
Thank you very much. As we are running a little behind schedule, we shall be taking 1 hour, so we should be finishing 10 minutes later. I'd like to invite the expert panel for the vitreoretinal session, Dr. Rajpal, Dr. Amit Khosla, Dr. Avrinder Gupta, Dr. R.P. Singh,